Dr. Gauri. I would now invite Dr. Saloni Joshi for a presentation on paradox in the eyes, a case of bilateral acute secondary angle closure glaucoma.
Good morning. Today I'm going to present an interesting case which can be easily missed in an OPD setting. It's not coming. Paradox in the eyes, a case of bilateral acute secondary angle closure glaucoma. A 66-year-old male presented to OP on 12th of October with sudden painless diminution of vision in right eye. He was a diabetic since 3 years and a hypertensive patient since 1 year. On examination, he was diagnosed to have rhegmatogenous retinal detachment in right eye, and the left eye had brown cataract. He was taken up for RD surgery, and after initiation of surgery, a break with subretinal hemorrhage was noted at macula, which was suspected because of peribulbar block-induced perforation, and it was drained to the maximum. Otherwise, the surgery was uneventful. Prone position was advised, and routine post-op medications were advised along with tablet astazolamide for 5 days. The next day, to our surprise, the visual acuity in left eye had decreased. The IOP in both the eyes was high. There was conjunctival chemosis in both the eyes, and the anterior chambers were shallow. Gonioscopy revealed closed angles in the left eye, and so a glaucoma referral was made. B scan was done, which revealed an oil-filled globe in right eye, and left eye showed shallow CDs. We thought that the right eye findings were because of the RD surgery, and in left eye, considering CDs, shallow AC, and high IOP, we considered the following differentials, which is VK8 syndrome, uveal effusion syndrome, and sympathetic ophthalmia, since there was an iatrogenic trauma. But these were ruled out clinically. And we came to a probable diagnosis of some form of secondary angle closure. PI was not done due to CDs and inflammation, and the patient was started on maximum possible anti-glaucoma medications. Tablet astazolamide was continued, and rest of the post-op medications were continued. But on POD2, the IOP had further increased, the conjunctival chemosis had also increased, and the anterior chambers were now totally shallow with 360-degree iridocorneal touch. So here, and the B scan was repeated, which shows a worsening of CDs. So here we have a patient who presented to us on POD1 with CDs, shallow AC, and increased intraocular pressure, which worsened on POD2. So a cross opinion from a senior medical officer was taken, and the diagnosis was revised to oral astazolamide-induced acute secondary angle closure. Since this is a bilateral condition, we thought that the CDs in right eye may have been masked because of buccal effect. The tablet was discontinued immediately, and rest of the medications were continued along with anti-glaucoma medications. On POD3, the vision was improved, the IOP had also decreased, and the conjunctival chemosis had reduced. So we discharged the patient with anti-glaucoma medications, and he was asked to review after 5 days. When he reviewed, the IOP was now normal. The conjunctival chemosis had also decreased, and the anterior chambers had started forming well. When he came after, the B scan was repeated, and it showed that the CDs were resolving well. When he came after 3 weeks, the IOP was completely normal, and anterior chambers were also well formed. So the AGM were stopped. So what's different in this case? Even though it's not uncommon, it can be easily missed. It is an idiosyncratic reaction to astazolamide, though topiramate-induced angle closure is more common. It is a paradoxical simultaneous bilateral acute angle closure due to choroidal effusion, and it always occurs after the initial priming dose. The first dose will be the sensitizing dose. Timely withdrawal of the offending agent is a must. Topical anti-glaucoma medications can be given to control IOP. Cycloplegics will help to alleviate the pain as well as form the anterior chambers. Steroids can be given to control the inflammation. YAC-PI should not be done, and myotics are avoided as they further increase the blood aqueous barrier breakdown breakage. Various case reports have been noted in literature, and mostly all are noted after cataract surgery. It's indeed a strange paradox because the drug which is used to treat IOP ended up causing the same. It is an ophthalmic emergency, and the fine line between acute primary angle closure and acute secondary angle closure has to be differentiated since the treatment management is entirely different. Pilocarpine and PI have to be avoided in these patients. Patient education about warning symptoms like blurring of vision, conjunctival chemosis, halos can be given, and also the doctors should be made aware of the set of drugs leading to idiosyncratic reactions. Thank you.
I had only one query. Usually in a silicone oil filled eye, you don't get B-scan images of posterior segment. B-scan in silicone oil filled eye is not very easy, and you are giving your pictures are crystal clear, so I'm a little surprised with that.
Also, you could have done one non-contact, a contact procedure in the other eye, which could have helped you in diagnosing. Can you think of any investigation that you could have done?
ASOCT.
That is non-contact, contact. UBM.
UBM could have been done.